So you and your partner have been dispatched to a local park for a female party having a seizure. Unfortunately, you are right around the corner from the scene. So you pull up and find the patient outside on kind of a pathway, and she's actively seizing. So bystanders state she was acting funny, kind of asked one of them for help, and then collapsed and started shaking. They called 911 immediately, and the seizing actually stopped once for around a minute or so, but then started back up again. The first seizure lasted what they think is around 2 minutes, and so far, so has this one. So the patient's actively seizing in front of you with clonic movement. Your partner and some firefighters transfer the patient to the stretcher and kind of load her into the ambulance. And then you ask the bystander some questions and obtain basically the following information. None of them know the patient, and none of them saw anything prior to the seizure. So you join your partner in the back of the ambulance and you perform a quick assessment. And you notice she stopped seizing, and your partner said she stopped around 30 seconds ago. So you perform a physical exam. For an airway perspective, there's a small amount of bleeding. It looks like she bit her tongue and she's got a little bit of snoring respirations. From a breathing perspective, she's got a respiratory rate of around 10. She's kind of got a grunting breathing going on, but her lungs are clear. From a circulatory perspective, she has strong radial pulses. She's a little tachycardic. From a disability perspective, she's essentially unresponsive. She's postictal, and she has kind of a big hematoma to the back of her head from the fall. And then from an exposure perspective, you see that she has a medical alert bracelet. So essentially, from the bracelet, you can see that she has epilepsy. And on the back of the bracelet, she has her name, which is Sarah Doe, and then her birthday, which makes her 18. And then a firefighter comes up and hands you an empty bottle of phenytoin, commonly called Dilantin. So the patient has tonic movement for about 5 or 6 seconds, followed by clonic movements again. She's seizing again. So your partner was able to obtain some vital signs just before the seizure. So she has a heart rate of 120, a blood pressure of 96/62, a respiratory rate of 10, and an SpO2 of 93% on room air. And your partner looks at you and asks, "Why do you think she keeps seizing?" So this patient has a history of epilepsy and is in status epilepticus. She takes Dilantin, which is an anti-seizure medication that looks like it wasn't refilled. So let's talk about seizures, epilepsy, and then most importantly, status epilepticus. So around 60 million people in the world have epilepsy. Epilepsy is a brain disorder that causes reoccurring unprovoked seizures. With seizures being the kind of clinical manifestations of abnormal increased synchronized electrical activity within the brain. There used to be like 30 different terms and classifications of seizures. It was kind of the bane of existence for like many a EMT student. When I was in EMT class, there was like 30 different things you had to remember. However, recently, and as of 2017, the epilepsy community kind of got together and straightened their stuff out. So we can classify seizures in two main ways: focal or generalized, and then convulsive or non convulsive. I want to focus on status epilepticus in this case, not kind of general seizures. So I'm going to skip like 99% of all of this. What's important for this patient is Sarah here has generalized seizures. These are seizures that involve both hemispheres of the brain. Generally, seizures can be kind of convulsive or non convulsive generalized seizures. Currently, Sarah's seizures are convulsive. However, as the seizure progresses, especially once her body starts to get really tired, they can become non convulsive. So you can have someone who starts off as convulsive and then become non convulsive. So she's having tonic-clonic seizures, which is the type of convulsion characterized by a tonic phase followed by a clonic phase. And this is actually mixed up a lot. So let's be very specific. These words don't describe the motion of the seizure back and forth. The tonic phase is bilateral increased tone, or that like tensing aspect that you see in that first picture. And that could last seconds to minutes. And then the clonic phase is that bilateral sustained rhythmic jerking. People think the rhythmic jerking back and forth is tonic clonic, and that's not the case. Tonic is the first part where the patient gets kind of rigid. They often like make a weird sound, they get really rigid, they tense up everything. Then the clonic phase is the actual rhythmic jerking. So why does this happen? To be honest, no one really knows. The brain requires communication among organized networks of neurons to function. This communication is driven by electrical activity that's created by gradients of ions like sodium and potassium across neural membranes. Just like in the heart, right? We learn a lot about the heart and the heart's kind of electrical system. When you go through paramedic school, it's the same concept in the brain. It's just, I mean, it's slightly different, but it's the same concept, right? Um, Neural firing, electrical activity, results in the release of neurotransmitters, things like glutamate and GABA. Hopefully, you've heard of both of these because those are the two important ones when it comes to seizures. Glutamate is the chief excitatory neurotransmitter, while GABA is the chief inhibitory one. Glutamate causes kind of a increased electrical activity, whereas GABA actually suppresses it. So seizures happen when these processes get messed up. Usually, this happens when excitatory activity is way too high or dysregulated. So there's usually a balance between excitation and inhibition, and sometimes for whatever reason, this gets dysregulated. So seizures themselves are usually self-limiting. So seizures usually stop spontaneously without any medical intervention. Uh, this is probably due to either running out of the excitatory neurotransmitters or the ion, or kind of a reflex over activation of inhibitory systems. No one's really super sure. Sometimes this is just happens to people, right? They have seizures. It's characterized as epileptic, and this is just something that they were born with or naturally developed. Other times, it's caused by kind of eptogenic, wow, eptogenic insults and kind of head injury, stroke, those types of things. Sometimes it's caused by changes in brain chemistry, like with electrolyte abnormalities or infections or drugs or withdrawal. Seizures can be caused by a whole bunch of things, and basically anything that dysregulates the brain in any way can potentially cause a seizure. So the period during the seizure is called the ictal period. Once these patients stop seizing, they enter what's known as the postictal period. This is a period basically following the seizure that's characterized by confusion, altered mental status, lethargy, that type of thing. And it usually lasts less than 15 minutes. It's almost always lasts less than an hour. And it's kind of a completely normal and expected course after a seizure. So people with epilepsy takes meds to control this. There's a whole bunch of different kinds, and different countries actually have different kinds. So here's kind of just a general list, but know that it's not all inclusive. So most anti-seizure meds alter the seizure threshold to prevent the patient from having seizures, and then some meds are considered rescue medications, like different benzos people take at home, that kind of a thing. But Sarah's seizures haven't stopped. She keeps having them, probably because she hasn't had her med in a few days, but there could be a bunch of other reasons. Sarah's now in what's called status epilepticus. So, status is kind of a subset of generalized seizures where the seizure doesn't stop for more than 5 minutes or there isn't a return to baseline mental status between two or more seizures. The definition when I started EMS was 20 minutes, actually, not five. And it turns out that that was way too long, and data showed that seizures lasting more than 5 minutes tended not to end spontaneously. So Sarah's seizures have each lasted around 2 minutes, and then she enters her postictal period. But then, within like another 60 seconds or so, she has another seizure. So she stays in her postictal period and never returns to her baseline mental status, which, she meets kind of the second definition of status, because she keeps seizing without that return. So this means that we need to stop her seizures for her because she's not stopping on her own. So, status epilepticus is a true medical emergency. It kind of starts out as a normal generalized seizure, but then it doesn't stop. So, this can be promoted by a whole bunch of different things, but the most commonly reported kind of etiologies are um, low antiplatelet drug levels, cerebral vascular disease, stroke, metabolic disturbances, specifically like electrolyte abnormalities. A big one is sodium disturbances, CNS infections, encephalitis, and there's a whole bunch more. These are just like the more prevalent of them. So no one really knows why this happens pathophysiologically, though. It's believed to be caused by several different molecular changes that all kind of happen in unison. So basically, kind of a perfect storm of brain activity, if you will. So this allows the usual kind of seizure to evolve and sustain itself. So this continuation promotes hyperexcitability while simultaneously downregulating things that inhibit seizures. like GABA. So this is why it's important to treat seizures aggressively and really early. So the earlier, the better, because the longer the patient seizes, the harder it is to actually stop. Most of the seizure meds work by promoting inhibition, but the longer the seizure happens, the more downregulated these receptors get that these drugs bind to, and then they downregulate and go away. And this happens within, you know, 10 minutes, 15 minutes. So prolonged seizures can actually cause a lot of problems for us, from anything from permanent neurological injury to fluctuations in cerebral perfusion to decreased brain oxygenation to different life-threatening systemic complications like respiratory failure, acidosis, hyperthermia, rhabdo, and then just trauma from the movement itself. So, what are our biggest concerns with Sarah? So, for starters, she has some potentially life threatening issues. Ongoing seizures with unprotected airway and risk of aspiration being one of them. Hypoxia and hypercarbia, right? Seizing patients aren't breathing. She's kind of holding her breath every time she seizes, and she really isn't breathing great when she stops to begin with. Um, she has evidence of head trauma. So, what came first? The seizure, the trauma, we can guess, but we don't really know. So, with all of that in mind, pause the video and ask yourself, what are your top management priorities? Really, we have two kind of immediate treatment goals here. The first, supportive care, right? Your standard ABC kind of stuff. And then two, we need to stop the seizures. Seizure termination is going to be key. So let's start with A, airway. You need to ask yourself basically, do I need to secure her airway? For starters, let's drop an NPA, right? She really isn't breathing during the seizures, and she was snoring last time she was projectile. So let's kind of start protecting that. So, do we need to intubate her? So let's look at reasons behind intubation: failure to oxygenate and ventilate, failure to protect the airway, and then kind of an anticipated clinical course. I'm not gonna lie, you can kind of justify intubating with all three of these, right? She's apneic, so she's failing the oxygenation and ventilation part. She isn't protecting her airway during the seizures because she can't. And you can argue that she could vomit, has injuries, she'll need a CT, she'll need EEG. And if you wanted to get away with the anticipated clinical course one, you probably could. However, what's the caveat to intubation and the caveat to kind of these three things? Correcting reversible causes first. A seizure, at least to me, is a potentially reversible cause. So we can stop their seizure and that might fix her issues. So she still might need to be intubated afterwards, sure, but we need to try to stop the seizure first to try to find out. So I'm sticking for the NPA for now, and we'll kind of keep a plan in the back of our head to intubate her maybe, but it's something we're not going to do right this second. BLS airway is kind of the key here right now. Moving on to breathing. Um, at this point, we should probably put her on some form of oxygen. So we'll use an underbreather for now, and we can escalate or de-escalate later. When in doubt, if you're not sure, and if a patient's starting to get hypoxic from seizures or really anything else, throw them on an underbreather first. And then you can de-escalate therapy or escalate therapy afterwards. In the immediate time, correct the hypoxia, and then we can wean down in a few minutes. So I also like to keep a BVM within reach just in case, right? If things continue, need to be something to consider. Especially, she sometimes stops, goes for 2 minutes, sometimes stops. Some of these patients will just seize for 10, 20 minutes, and they're not really breathing effectively that entire time. You're gonna have to eventually kind of support them. So moving on to C for circulation, she doesn't actually look that bad from a circulatory perspective. We need an IV. However, I want to prioritize stopping her seizure before we get a line. And I don't really need an IV for that. I want one, right? But it's just not the top priority. So now let's take a closer look at disability. We need to stop these seizures and we need to get a glucose. So your partner gets a glucose for you and it's 165 or 9.2. So how do we want to stop the seizure? The recommendations currently is if you have an IV, is to use lorazepam, and if you don't have an IV, to use IM midazolam. And most EMS services carry midazolam and or lorazepam anyway. So for here, let's give midazolam, right? The Rampart Trial, which came out in 2012, was a pre-hospital study that looked at EMS patients and status epilepticus, and basically concluded that IM midazolam was not inferior to IV lorazepam. Basically, it showed that patients who received IM midazolam prior to arrival to the ER were less likely to be seizing, and were less likely to be seizing upon arrival, and were less likely to require hospitalization. So I'll take it, right? Uh, but here's the caveat: you need to give the right dose. For some reason, EMS systems way underdose their benzos. The dose of midazolam in the Rampart study was 10 milligrams IM for a standard sized adult, basically anyone over 40 kilos. So let's go ahead and give her 10 milligrams. So benzos are the first line treatment in status epilepticus. It's benzos, 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 more benzos, up front and early. Why? Because as it turns out, they're really good at stopping seizures. Seizures are an excitatory problem. Benzos are inhibitory drugs, right? They're GABA promoters. And around two-thirds of patients in status will actually break with benzos alone. So the majority of these patients, you just need to give it early and give it appropriately. So right after you give her your midazolam, you head to the hospital. It's about a 10-15 minute drive to your regional medical center. It's like a level 2 trauma center. It's got neuro capabilities. It's a decent sized regional hospital. And good news, the patient stops seizing. So you reassess, you start a line, you hang some fluid, you place her on N-Title, uh, and she's unresponsive, but you kind of expected that, and your PLS airway is working great. She's no longer snoring. You put her collar on for C-spine protection, especially with the head. You're not sure if she fell and smoked her head, if she was injured first. We're still kind of chicken or the egg, and you're about 3 minutes out from the ER now, and she starts seizing again. Turns out she's part of the one-third of patients who do not break with the first round of benzos. So now she's in what's called established status epilepticus. She needs more drugs. So you draw out more Badaz per your protocols, and you give it IV this time. And she'll also need some longer-term anti-seizure or anti-epileptic drug in the ER. So according to the American Epilepsy Society, right, the next thing we're going to do is we're going to give an anti-epileptic. There's multiple choices from phosphonatoin, valproic acid, or Keppra. Keppra is probably the most popular one at this point. You can also do Venobarb and stuff like that. So usually, depending on which guidelines you're looking at, you'll give a second dose of your benzo, and then you'll give an anti-epileptic. Keppra is definitely the most popular. Not all EMS agencies carry these. Basically, there was a big study that came out, and I can't remember the name of it, but if I remember to, I'll put it in the comments under this video. They basically looked at all of these different anti-epileptic drugs, and they found they were all essentially equivalent. I personally like Keppra just because, one, it's super easy to dose. It's just 60 milligrams per kilogram. And you can just run it in over 10 minutes. So you can put it in a 100 bag and let it just kind of drip in. So it's easy to give. It's effective, and it has no contraindications and no major side effects, whereas the other drugs have a lot of side effects, even if they're equivalent to Keppra. I favor Keppra. Like if I was working my flight job, that's what we give for a lot of these patients. However, use what you have, and if you don't have any of these, don't worry about it. A lot of EMS agencies don't. However, ketamine may also play a role here, but a lot more research is kind of needed. So, ketamine has an established anti-seizure properties and is recognized as a treatment option for what's called super refractory status epilepticus, so like the fourth box down. It's readily available to EMS, right? Most agencies carry it at this point because what's nice with ketamine is remember that in status epilepticus, there's a downregulation of those GABA receptors. There's also an upregulation of NMDA receptors. Turns out ketamine is an MMDA drug. So those receptors that are actually upregulated is what ketamine hits. And your benzos, which are GABA drugs, those are being downregulated. So ketamine is probably a great option. We know it's an anti-seizure medication. It's recommended later on in the algorithm. Maybe we can, especially in the EMS setting, kind of move it up to this round. There's actually a great article that just came out recently that kind of reviews this option. You can see it here. I highly recommend you go and read it. It's written by a paramedic. Shout out to them. So check that out. So you pull up to the ER, you bring the patient in the ED, and you give your handoff. Here's just kind of how I give handoffs. There's a million ways to do this, but here's mine. So basically, hey everyone, I'm Dean. This is Sarah. I always like to introduce myself and the patient. Sarah is an 18-year-old female with a history of epilepsy. She's on Dilantin, and she's had several witness seizures in front of EMS without return to baseline. This current seizure has lasted approximately 3 minutes. She's been refractory to both IM and IV midazolam, and then she has a hematoma to the back of her head without bleeding. Her last set of vitals prior to this seizure were a heart rate of 132, blood pressure of 97 over 68, respiratory rate of 14, SpO2 is 97% on an on her breather, and her end title's in the 50s. Her blue glucose was 165. She has an 18 gauge IV. We have an empty bottle of Dilantin that was found in her bag that ran out 3 days ago. We don't really have any other information. Do you have any questions? And as it turns out, they didn't. Uh, so in the ER, she started on a phenytoin infusion and given some lorazepam before ultimately being intubated and started on propofol. Propofol is a very powerful antiepileptic and has a very good track record of stopping seizures when used appropriately. You usually give a bolus of propofol and then you hang a high dose infusion. You have to be careful because of the triglycerides and stuff like that, and propofol infusion syndrome and all of that. But in the short term, propofol is a very powerful anti-epileptic. I actually used it 2 days ago on a status patient and worked great. So she was admitted to the ICU where she was placed on EEG monitoring. She basically was on a high dose propofol infusion, and ultimately is what stopped her seizures. She was discharged 5 days later for close follow up. And basically, our initial thoughts were right. She ran out of her Dilantin. She hadn't taken it in 3 or 4 days. And her status epilepticus was just attributed to that. Didn't really find anything else. And that's it for the case. So thanks for checking it out. I hope you learned something you can take with you on your next shift.